Thank you very much for this nice psychometric study of autism questionnaires. We proceed with the next speaker, Hanna Swaab. She's a professor of neuropsychology at Leiden University, the Netherlands. And the title of her presentation will be The Differentiation between PDD-NOS and MCDD based on cognitive dysfunctioning. Prediction of high risk for psychosis, question mark, question mark, question mark.
Well, thank you for your introduction and for the opportunity to speak here today. This presentation is about a possible differentiation between PDD-NOS and a subtype of multi-complex developmental disorder based on neurocognitive characteristics that might predict serious psychopathology later in life and even possibly psychosis. Research mission of our group, of our groups, I have to say, because it's a collaboration between Leiden University and the University Medical Center in Utrecht, is to find predictors of developmental outcome in neurodevelopmental disorders. And our particular interest goes to those factors that predict very serious outcome later in life, like psychosis. In other words, our mission is to find tools to early identify those children that will not be able to cope with the high demands of daily life and that will develop very serious problems. This is our research model. Genetic makeup leads to brain development, of course, in close interaction with environmental factors. Brain development leads to brain functioning that is expressed in behavior or in behavioral problems, the phenotype. We are particularly interested in the neurocognitive functions that are considered candidate endophenotypes that are an expression of brain function and that are underlying the observable behavior. Environmental factors can influence development and functioning at every level, of course, at least to a certain degree, but especially in vulnerable children. And there is also our chance and our possibility for interventions and treatments. So in trying to unravel the developmental pathway to psychosis and to identify those neurocognitive characteristics that might indicate a high risk for psychosis or severe outcome, we studied a very vulnerable group, children with PDD not otherwise specified. All of these children show high levels of social problems, which are a known high risk factor, but some of them develop with high or more or less high stability into adulthood, whereas others deteriorate and become seriously ill later in life. Cohen already described an unstable and vulnerable high-risk subtype of PDD-NOS in the 80s, and the research of Van der Graag and Buitelaar of the Utrecht group resulted in the publication of a diagnostic classification rule for multi-complex developmental disorder in 1998. MCDD children were identified within the PDD group based on high levels of anxiety, problems with emotion regulation, affect regulation, and high levels of thought disorder, in addition to social problems. In follow-up studies, those MCDD children appear to have high risk for psychosis, or more specific, for schizophrenia spectrum disorders later in life, although there's still discussion going on about these findings and more research has to be done in outcome studies. However, Janssen, also part of the member of the Utrecht group, found evidence in 2003 that MCDD children show different cortisol responses to social stress compared to autistic children, which can be considered as some biological validating evidence for the MCDD concept. Today I'd like to discuss data from one specific study. In this study we compared 24 children that met the criteria of MCDD to 22 children with PDD, not MCDD. Some characteristics of the group can be seen here: IQ, gender, which were not different between those groups. Based on prospective studies that identified neurocognitive domains that might be important in prediction of psychosis or serious psychopathology, we were especially interested in the domains of verbal fluency, verbal memory, attention regulation, and executive functioning, which is a very broad and ill-defined domain that we narrowed down for this study to inhibition. We measured verbal memory with a verbal learning test that might be considered a test of episodic memory, meaning that this task measures learning of recent and specific information, verbal information, specific for time and place. We did find no differences in learning speed and no differences in delayed recall, so no imprinting problems or no imprinting differences between those two groups, or long-term storage problems were different between those groups. But MCD children had significant more difficulty with recognition of learned verbal information, meaning that stored information can be easily infiltrated by other information if presented within the context of other information, which might probably be due to difficulty in selectivity, which might be an attention and inhibition problem. Well, attention regulation and inhibition have to do with information processing. The individual has to cope with a lot of incoming information from the environment that asks for processing and storage and for response. To be able to adequately process some parts of this huge amount of information, one has to be selective. Something we all have experienced to cope with those days in choosing the lectures we had to go to. The ability to focus and to selectively ignore parts of information asks for inhibition of further processing of the screening, called focused attention. Selection is necessary because of limited processing capacity within the individual and because of relevance and efficiency. Selection is therefore considered a very important tool in controlling learning and thought and cognition, and eventually in controlling behavior. This is especially important during childhood and adolescence because it helps the child to selectively learn and build a useful and coherent internal representation of the surrounding world that gives meaning to incoming information. Speed of processing is considered a measure of efficiency of processing, and roughly we differentiate between inhibition of processing and inhibition of responding. Accuracy is a measure of selectivity and inhibition, so we differentiate between early and late inhibition. During this activity of selective information processing, we also look at the capacity of the individual to sustain this control during processing for a period of time. Especially this sustained attentional control is important for adequately adapting to situations in daily life that ask for control of processing, like for instance in school during education. For measuring this, we use computerized reaction time paradigms to be able to measure these aspects. Attention regulation was measured with the classic visual CBT paradigm, measuring sustained attention and regulation. And again, we did find no difference in speed of processing of information, but MCD children had high fluctuation of speed in processing, which is considered a strong indicator of attention allocation problems. Moreover, they showed significantly higher level of errors of inhibition, again reflecting the inability to control information processing and to select relevant information. They were not responding to feedback that was given to every error in this specific task, meaning that they could not restore their control over information processing even after explicit feedback. And there was a clear deterioration in performance during time on task, so there was not much control, not much sustained control over the processing of information in MCD. And in a specific inhibition task, focusing on response inhibition, they showed much more impulsive errors than the PDD, the other PDD children. So this showed that they had difficulty selecting the adequate response after processing the information. Summary of these findings of differentiation between those two groups. MCDD children show much more problems in allocation of attention, which means much difficulty in selection of information that should be processed. They have significant more difficulty in sustaining attention allocation and in sustaining control over processing of incoming information than PDD children without MCDD. They show much difficulty in inhibition of information processing and in inhibition of responding to irrelevant information. They also have difficulty in correcting their attention allocation and response control after immediate feedback. So here's a visual summary. You can see that difficulty can be found at selection of processing and selection of response, and in sustaining this control during processing. So in comparison to PDD children, MCDD children show much less control over processing of incoming information and responding to it. In general terms, allocation of attention and inhibition are supposed to be important and strong tools in gaining control over the surrounding world and its complex information. And those tools are supposed to make it possible to make sense of incoming information, to build an adequate, meaningful representation, and being able to respond adequately. So an implication of this finding might be that a child is unable to develop, the MCDD child is less unable to develop adequate coping behavior and has difficulty to cope with complexity. So with respect to our research mission, we can conclude the following. The inability of attention allocation and the inability to inhibit and control information and to narrow it down to bits that can be adequately processed might be a factor in social dysfunctioning and in high risk for deregulation of thought and behavior, which are elements or might be elements of psychotic disorder later in life. It's important to bring to your attention the multiple findings of high levels of attention problems in PDD that show that attention regulation problems are frequently found in PDD. Based on our findings, I want to conclude with a statement. Attention and inhibition problems might be a useful dimension of neurocognitive functioning that deserves specific diagnostic attention within this group of vulnerable children that might help identify high-risk children and might have implications for treatment. Proof of this statement, for this statement, has to come from follow-up research, of course. We are doing this follow-up research already on the children in this study, and we hope to be able to present to you our follow-up results in the near future. Thank you for your attention.